Sorry, can I just ask to stop? There's a bit of chit chat in the chamber because we're now live. So in the chamber we have Cllr Patrick and Cllr Adams and myself, and we're joined by Cllr Adebayo online, and I think we're shortly to be joined by Cllr Samatar as well. We have apologies from Councillor Claudia Turbat-Delov. I'm just going to go through the standard points. This is a hybrid meeting, so people in the chamber, people online. Please can you keep your microphones off unless you're speaking. Please keep your cameras on when it's your item. Please be aware we're being live streamed, members of the press sometimes watch. Please don't start chat because I won't be paying attention to it. If you need to make a contribution or you'd like to, please raise your electronic hand. Now, declarations of interest, are there any, please, members? I haven't been notified of any and I don't see any. And so with that then, let me go to the first item, which is an urgent item of business, and I'm grateful both to Councillor Selman and also to Health Watch Hackney for raising with us. This relates to people with acute mental health needs presenting at places of safety, of which the Homerton is one. Often this will arise as a result of the police possibly bringing somebody in through what is known as a section 136, e.g. they are a danger to themselves or to others, and there's a particular pathway within those places of safety, and we've been notified of particular concerns in terms of the wait for those individuals should they be diagnosed as needing an inpatient bed. And I understand, I'm grateful, we spoke to Nina, who's going to present on this briefly in a minute. Just to recap the figures, as we understand it, there's a sort of suggested that nobody should be waiting for more than 12 hours from the point that they've been diagnosed as needing a mental health inpatient bed. And in September, as I understand it, 20 people were waiting at the Homerton for more than those 12 hours, awaiting an inpatient bed post-diagnosis. And in October, that was 23. So it's an ongoing high issue. I understand Nina's going to tell us about what's been going on to try and address that. Nina, I won't steal any more of your thunder than I already have. So Nina, over to you.
Thank you, Councillor Hayhurst. So
you're a bit quiet there. Is that us? Oh.
Can you hear?
Go again.
Is that any better?
That's better, yeah, thank you.
Okay, let me know if you can't hear me. So yeah, this has been raised by Health Watch and at least one councillor today, and I think it is an important issue that this committee should be aware of. So just to put a bit of context around this, so it is quite common for people in mental health crisis to be taken to emergency departments, so such as Homerton Emergency Department and emergency departments in other hospitals. And that is because these are deemed to be safe places where people can seek a mental health and a physical health assessment and can wait to access further services that they may need. And that is a common pathway. And as Councillor Hayhurst said, it is very common for the police to often bring these types of individuals to A&E departments. We measure waiting times in A&Es, and one of the kind of drop dead markers, one of the markers that we really look out for is the amount of time that people wait from a decision to be admitted. So from when a decision is made that they need to be admitted, either to a mental health bed or to an acute physical health bed, to the point that they are admitted. There's an absolute kind of national diktat that no one should wait for more than 12 hours. And historically, very few people did breach that 12-hour waiting standard. And indeed, to date, in the Homerton, very few people waiting for Homerton physical healthcare beds do breach that standard. But what we have seen in the past 8 months is an increase in the number of people who breach that 12-hour waiting standard, who are waiting for a mental health inpatient bed. To put a bit of context around that, that is an issue that is being seen pan-London. So yes, we are seeing it locally, but it is also being seen pan-London. And it goes hand in hand with increasing demand on all of our mental health crisis services, and indeed on our mental health beds. So that's the kind of context in the picture. First thing to say is, it's not an acceptable situation. All partners locally recognise that it's not appropriate for people who are in mental health crisis to wait for such a long amount of time and not be able to access an inpatient mental health bed when that is what they need. And there's been quite a significant amount of work and attention on this, both at a local city and Hackney level, at a North East London level, and indeed even at a London level. This did get escalated to a London chief exec's call last week or the week before. So there is significant attention on it. To put a bit of, I'm going to look locally. So looking at it locally within City and Hackney, the teams here, as I said, we are seeing overall increased demand on our inpatient beds coming through those mental health crisis services. But we've also seen an increase in length of stay within our mental health inpatient wards. So those two things together is what is creating the pinch point and the blockage and causing people to wait longer for those beds. So what is the solution? So the first thing that we've done is, through this winter, we will be putting in place extra capacity in two places. One, there is work underway within the ELF site to create extra, what is called 136 suite capacity. So that is extra space away from A&E within the Rayball Centre, which is on the ELF site, to create a safe.
That's on the just to clear, that's on the Homerton site, isn't it? Sorry, did we just miss that? Yeah, thanks.
Yeah. Sorry, it's on the ELF part of the Homerton site, so it's just a short walk from the A&E. But it is away from the A&E, and that's quite significant because that creates a calmer environment for people who are in mental health crisis. So there are capital works to create extra, essentially, and extra capacity for people awaiting mental health beds, and that capacity being a bit further away from the A&E makes it more appropriate for those individuals, and also takes some of the pressure off A&Es as well. That new suite will be open in January. The second thing that is happening is that ELFT are procuring an additional 40 independent sector beds, inpatient beds. So they're procuring extra inpatient capacity to try and take some of the pressure off their inpatient wards. The plan will be that those extra beds that they commission in the independent sector will be for out-of-area patients, therefore releasing the main ELF beds for in-area patients. And the reason for doing that is, in an ideal world, you would never put people into out-of-area mental health beds, because when they're in beds in their own local areas, they have the wraparound care from community services and social work services from their own local areas. So therefore, we're trying to ensure the best optimal pathways as far as possible by keeping our in-area patients within local beds where they can access those local services. But that extra capacity should free up significant beds within the system to be able to do that. And then finally, the third area, the kind of solution, is looking at that length of stay and that flow. So as I said, we have seen an increase in length of stay in our mental health beds. And so there's quite now a significant focus on that. Colleagues are probably aware that additional discharge monies have been announced through the Adult Social Care Discharge Fund. Part of those monies locally will be going on mental health discharge. So there will be focus and attention on mental health discharge. In addition to, and separate to that, we've also commissioned additional B&B step-down capacity in B&Bs to support people who can't be easily discharged into their own homes. There's also a significant programme of work being led through ELFT, just looking at how they really support flow through their wards and really maximise flow through wards and try and bring their length of stay back to what it was previously. So that summarises, I think, the position and the work around this. As I said, this is a subject of huge amount of attention. We talked about it in the Neighbourhoods Health and Care Board the week before last, and we've also got another conversation about it at the City and Hackney Health and Care Board development session on Thursday.
Thank you, Nina. Just before I throw it up open to any questions, I think, I don't know whether you've had a chance to find out, one of the things you helpfully just gave Charlotte and I a briefing beforehand today. In terms of the additional funding, I mean, one of the things I was just worried, if we be able to find out where possibly the source of the money's come from, because obviously paying for 40 independent sector beds is quite a funding commitment, and I'm just sort of wondering whether that's at the expense of any other service, or where that's been found from, or is it just in reserves? And also, actually, one thing I didn't ask, you may not know the answer to this quite straight away, is how long is that funding committed for? I mean, is it for 6 months to start with, or do we have any commitment on that?
Yeah, so the funding is from specific mental health winter monies, so it's not being taken out of anyone else's pot. Initially, that is just until the end of March, and then the situation will be reviewed to see what the pressures are like closer to the end of that time.
Thank you, Nina. Questions from colleagues. Cllr Samatar is joining us via telephone, so Wi-Fi is down. And also welcome to Cllr Baffour, who's also joining us online. This was for a sort of AOB, so this isn't a main item, but I will take any quick questions if there are any from members. I'm looking around. I don't see any hands. Cllr Adams.
Yes, I just want to, ask a quick question about when you think we're going to be seeing the pressure being relieved with all these measures that you put in place, or you plan to put in place. When can we actually start seeing the impact, in reality? Thank you.
Yeah, I mean, I think we'd expect to see it from January when the new capacity is in place. I think.
Yeah.
No,
well, thank you. I mean, I suppose the interesting thing will be to see if the funding's there till March, and that particular winter funding, etc., whether it becomes more of a long stay issue, etc. I mean, I think one thing maybe is we could pick this up maybe around February, March time, again, maybe as a more formal item, just to sort of see where we're at, where the situation's at. I mean, obviously there's a background here that there has been historically a reduction in mental health beds across North East London, and then it would be a bit of a perversity if we end up having to pay more for stock purchase in the independent sector when we just got rid of over the last sort of 3-4 years owning house beds. But that, I may be jumping the gun if this could just be a fairly short-lived spike, I suppose. So let's maybe pick it up in March. And thank you, Nina, for being prepared to come and give that helpful briefing to us. Can I then move on to what is our first substantive item, which is the integrated delivery plan. So this is the plan for our place, and we can see it in the pack, and we're grateful for it being produced. So members, it's from page 11 onwards of your agenda pack. And we've got Helen Woodland, who's the group director, and Nina, who's the head of delivery for City and Hackney Place-Based Partnership, who's the sort of the bridge director between the council and the integrated place. So I don't know if Helen, did you want to start, or is it straight over to Nina to start the presentation?
I'm conscious of time, so actually I'd hand straight over to Nina if that's all right, to give time for questions.
Thank you.
Cool.
Over to you, Nina.
Thank you. So I think most of this, I'll do a slight recap on the City and Hackney Place-Based Partnership, which most of you are aware of. Essentially, the Place-Based Partnership brings together all of the providers of health and commissioners of health and care services within City and Hackney. And we work together to try and think about how to improve the health, essentially how to improve the health of the population of City and Hackney, and improve people's experience of local services. Broadly, we work under the guise of what is called the City and Hackney Health and Care Board, which is co-chaired by Cllr Kennedy from Hackney and Councillor Fentiman from the City of London. So that's our kind of overarching governance. And then we have various kind of subcommittees and groups that meet underneath that overarching committee. This is a bit of an evolution of existing integrated arrangements that have been in place for a number of years in City and Hackney. So I'm sure members who've been here for longer will remember us talking about the integrated commissioning structure and the integrated care partnership board. So this is essentially an evolution of where we've been going, of the journey around integration for health and care services within City and Hackney. In sort of March time earlier this year, we agreed as a health and care board that we needed to set some strategic priorities. So we met as a health and care board and with wider partners to think about what is our local partnership strategy, what do we want to prioritise, what do we want to do to improve health and care services and health outcomes for our local residents. As a board, we obviously work really closely with the Health and Wellbeing Board. So I think we quite quickly agreed that we didn't want to create a whole new strategy as a health and care board, but actually what we would do would be to formally adopt exactly the same strategic focus areas as the Hackney Health and Wellbeing Board, and that we would support delivery of the Health and Wellbeing Board strategy. We also agreed that we would formally adopt the strategic priorities of the North East London ICS. And pages 4 and 5 in my pack, though they're probably not 4 and 5 in your packs, the section about strategic objectives describes how we've formally adopted those strategic priorities, both from the Hackney Health and Wellbeing Board and from the North East London ICS. And that those are the strategic priorities that we are driving locally within City and Hackney. And I think that shows that how, as a partnership, we absolutely want to deliver on those local priorities that come from that local health and wellbeing board, but we are also part of a wider North East London integrated care system, and we can see how the priorities of the wider North East London integrated care system are also very relevant to our local populations. What that resulted in was essentially us agreeing to 9 strategic focus areas. 3 of those strategic focus areas are focused around population health groups. So the 3 population health groups are: 1 around children, so giving every child the best start in life; a 2nd population health group that is around improving mental health and preventing mental ill health; and then a 3rd strategic focus area around preventing and improving outcomes for people with long-term health and care needs. So those are our 3 kind of strategic priorities focused around population health, population cohorts. And then we also agreed to 6 cross-cutting approaches that are relevant to all of those population health groups. So those cross-cutting approaches are around increasing social connection, ensuring healthy local places, supporting greater financial well-being, joining up health and care services, taking effective action to address racism, and then supporting the health and care workforce. So broadly, those are our kind of 9 strategic focus areas. What we also agreed to do locally was to organise our transformation programmes around those 3 population health focused strategic focus areas. So we've got 3 main programmes, one looking at children's services, one looking at mental health, and then one looking at services for people with long-term health and care needs. And that's how we've kind of organised our transformation structures locally within City and Hackney. So from those strategic focus areas, we then moved on to thinking about what are we actually going to do to address them? You know, what is the work that we're going to do to kind of deliver on this strategy? And that's where this document comes in, which is developing what we've called an integrated delivery plan. So this is a partnership developed plan that describes what we will be doing as a partnership, working together over the next 2 years to deliver against those strategic focus areas. Really importantly, it doesn't describe all of the work of all of our individual organisations. What it describes is where are we going to work together and where do we think we need to work together to improve outcomes for residents. It's been driven by outcomes. So there's been work with the local public health team through the Population Health Hub to think about what outcomes we want to improve through our work and what outcomes we think we need to improve. And as I said, it should be about how we work together to do that. There's quite a lengthy plan that sits underneath the document that I presented to you today, but what I've pulled out for you today is what we've called our big ticket items. So these are the key 9 areas where we see we want to drive the most transformation as a partnership and where we want to drive the most change. These are detailed in your pack. The pages are quite blue, and what I've pulled out is the 9 big ticket items, the kind of a key summary of what we're doing against each one, and I think more importantly what improved outcomes we would want to see against each of those big ticket items. As I said, we're really trying to have a focus on what outcomes we want to change. I'm not going to read them through to you individually, but you've got them, and I'm really happy to answer more questions. And as I said, underneath this document is a much more detailed delivery plan that sets out with kind of milestones what we're doing against each of these big ticket items. And what we've also got within the structure is a number of what we've called system enablers. So we have a workforce enabler, a digital enabler, and a VCS enabler, among others, that are doing the work to try and think about what are the key enablement activities that need to be done to support delivery of this plan. And some of the next key pieces of work is really trying to develop those plans of the enablers in more detail as well. We're also currently working to develop what we're calling a resident-friendly version of this plan. So hopefully within the next month, we'll have a document that is actually accessible to our residents, and we can share with our residents in a way that they can understand about this important work. A key other next step is pulling together what we're calling an outcomes framework. So a very clear document that pulls together exactly what outcomes we expect to see delivered and quantifies how we want to see the kind of delivery against outcomes as well. So those are kind of the 2 key next steps on this work as well. I'm going to stop there and open to questions from the committee.
Thanks, Nina. I can see Cllr Baffour, and I know Cllr Adams has got some questions as well. Before I go to them, can I just, and this is obviously something we're also addressing at the INEL Scrutiny Commission in a few weeks' time as well, with Henry, the Chief Financial Officer. The ability to achieve a lot of these strategic objections is premised upon Hackney having decision-making levers itself, and also the funding devolves to it through a scheme of delegation. So what's the best update you're able to give us with what the latest commitment is, from which what I understood to be April, which is when things would again go live after the year transition period, as to, for example, would the healthcare board be having the same level of and the same volume, same quantity and amount of decision making as the ICB before it, or would we be seeing a reduction there? And also, I was slightly concerned, I think, if that's not putting too strong a word on it, by Louise Ashley's comments at the last meeting, and Jalil's pulled out the quote. She concerned about devolving more commissioning down to place, as she did not want to see lots more additional work thrown down from the ICB without the resources to deal with it. So what, as best as you can speak for her, Nina, what was meant by that in terms of what is this committee's concern, that in fact commissioning will take place at a higher level, and then we'll lose the connection that we've got between commissioning and our local populations?
Yeah, so this is still a live debate, as you know, though, as you say, it does have to be resolved by the 1st of April. The first thing I can say is that the Health and Care Board has been constructed so that it is a formal subcommittee of the ICB. So that means it is being constructed in such a way that it can take delegation from the ICB. So there is an expectation that financial and decision-making delegation will be given to that committee. The level of that delegation is not yet defined. At the moment, there are 2 documents that are being brought to the various place-based committees for discussion, and we're having this conversation in Thursday in our City and Hackney Health and Care Board development session. The 2 documents, one is being described as a financial strategy. The second is what's called a place accountability framework. The financial strategy describes how the ICB is currently envisioning money flowing across partners in North East London. The second describes what they see place as being accountable for within the wider ICS system. The current proposals around the financial strategy are that money that NHS trusts will receive block budgets from the ICS, from the ICB directly. So for us, the Homerton would receive a block budget from the ICB directly for both its acute services and its community services, and likewise else would receive the same for their mental health services. The remainder of the health and care budget would then go to the places for the places to oversee and to govern, on the expectation that the place, so that the place committees would therefore have primary care and other non-NHS trust community-based voluntary sector services. But then there's also the expectation that Homerton come to the table as part of the place-based partnership, and in so doing, they come to the table with consideration for their resources and their decision-making as well. So that's the kind of broad kind of proposed strategy. There is also within that document a proposal that 1% of the ICS budget, the ICB budget, sorry, will be held back for transformation, and that partners and
the budget is 4 billion roughly, and so we're talking 40 million will be held back for transformation.
Yeah, that's exactly right. 40 million will be held back for transformation, and places and provider collaboratives will be able to bid on that transformation money if they can evidence that there is a good need for that money. Exactly what that process looks like has not yet been determined, and the exact criteria of how that 40 million will be used has not yet been determined. A really important context, though, that I think we can't forget is that at the moment we are in a really difficult financial situation. So we are seeing a deficit at a North East London level, quite a sizable deficit. So there are questions about the feasibility of being able to even hold back 40 million for such a transformation fund. There's also the live debate about whether that transformation fund could be used for anything apart from future cost-saving initiatives. So it could probably only be pulled on if you can evidence that you will make further cost savings through use of that money and investment in other places. So that's a really important context. In terms of, I think it's probably worth referencing the place accountability framework, which probably puts a bit of context around what Louise was saying at the last meeting. So the place accountability framework is a document that describes the kinds of things that the ICB are suggesting places should be accountable for. And I think it's we would see it as quite a positive document, because it puts quite a lot of accountability on places for doing a lot to improve the health of the population, keeping the population well, and responsibility for a lot of services that we would expect to be responsible for. So I think in that respect, it is positive. I think Louise is concerned, or that whilst we are still in a position where we do not exactly know the shape of what the ICB will look like as an organisation and how the human resources within the ICB will be organised, there is a risk that a lot of asks will be put on places without necessarily having the adequate people resources in terms of financial support, commissioning support, quality support, all those kind of people resources to really make sure we can deliver on those asks. So I think we want to make sure that we want to have accountability from the ICB, but we also want to make sure that the resources follow so that we can deliver on those accountabilities as well.
But just to understand the nuts and bolts of that last point, is that because, and trying to piece together with what Henry said in the past, so that the framework could work something along the lines of, yes, that notionally the money is delegated down to place, bar for the acutes, and say the decision rests with the HCB in each place. But from what I understand, because technically it all needs to be formally commissioned or contractually signed off at ICS level, that they sort of hold the bodies or the people to see that through, and that could create, unless we have sort of our own commissioners and our people to do the research and hold people to account and have that tier of management, as it were, that might not be a very popular sort of political thing, but a necessity to actually oversee good contract management. Unless some of that is given or allocated somehow to place, it could cause tensions. Is that sort of the rough area we're in?
Yeah, essentially that. So essentially the ICB is forming itself as an organisation, and it has not yet it is about to launch a full staff, a consultation with all its staff to describe how they see the staff being organised within the new structure. So we want to make sure that resources align to accountabilities. So where there are significant accountabilities, that resources also follow that to make sure that we can deliver on those accountabilities.
And so obviously the way you could, if you were a big commissioner at ICS level, you could commission on a thematic level, say, I don't know, across mental health, but that would be across, say, all 8 boroughs, but then you lose any form of connection to the individual places. Or you could divide your commissioning teams into the places, which is similar to what we've had at CCG level. Now, I suppose there's a danger of duplication there, but there's the advantage of local connection. Exactly. And so are we, and I'm looking to Cllr Kennedy here as well, are we advocating strongly for the latter to retain that local link?
Do you want me to? I mean, I think we need, it depends on the topic. I think a local link is incredibly important for nearly all of our agendas. But likewise, I think we also recognise there are some more specialist healthcare services where it makes sense to think about things on a North East London footprint. And there are some pathways that are North East London wide pathways, like cancer pathways, where it does make sense to think about the whole population of North East London.
Yeah, I agree, but that's always happened. There's always been a chunk in the CCG world. There was always a chunk going up to deal with sort of major, stroke, cancer pathways, because that makes complete sense. But Cllr Kennedy, Chris.
Sorry, yeah, I took my hand down rather than took myself off mute. Yeah, Nina's pretty much answered it, but ultimately the opportunity offered by the ICS is that you manage to get more of those economies of scale than you had before. And the threat that comes with it is that you lose all the local, hyper-local knowledge. And when Zena gets her team and her structuring right, all the way through it, it will be in a way, and this is what we keep asking for, that retains that local knowledge and expertise where we had it, and still affords her the opportunity of running a system that essentially saves the resource it needs to save by realizing those economies of scale. It's really tricky, and I think Nina's right when she says that's still very much an ongoing process, but all the noises coming from Marie as chair and Zena as chief exec are right, that they completely get that, and that we're on track for that to be what we get as a system.
Okay, thank you. I've got a few more questions, but I don't want to monopolise any more time than I already have. So, Cllr Baffour.
Yeah, thank you very much, Chair. What I wanted to know is, I think we've clearly understood the area of financial and the capacity building in terms of working with external groups and that sort of thing. But what we haven't highlighted specifically is about are you going to use the same number of staff to deliver the extra kind of the responsibility that you're thinking about? Or are you going to increase the number of staff to meet in terms of ensuring quality of service delivery and that kind of thing?
I'm afraid probably because the acoustics in the chamber here, I didn't catch that. Nina, did you catch that?
So I think you were asking about whether we're planning to increase the size of the workforce. Was that your question?
Yes, to meet the service that the responsibility that you are yet to confront with.
Were you talking about any particular part of the workforce, so any particular service?
Actually, in the whole structure as to how the new responsibilities that you are yet to take up, how are you going to meet that with the number of the staff you have currently, or you're going to you have in place something to increase it to meet or to achieve what is expected?
Are you talking about staff working within the place-based partnership who are doing the planning work, or are you talking about clinical staff within services?
The actual within the services as to how you meet the quality of service delivery.
Oh, yeah, of course. So so there's absolutely no plans to cut clinical or care workforce. But I think each individual service will be thinking about what they need to do to deliver safe and high quality services. Workforce planning really fits within each of those individual services. So with a place-based partnership, we tend to think about where there are opportunities for closer working or to deliver more integrated services. We don't generally get into the detail of exactly what level of workforce is needed in each of our individual services. That generally sits within the organisations. But we do often think about opportunities for new workforce, and where new workforce can sometimes alleviate pressures on more difficult to recruit parts of the workforce. So an example of that is some of the work that we've been doing within the Neighbourhoods team and within primary care networks to think about how you can bring in different types of roles to support pressures. So for example, we know that GPs, often we struggle to recruit GPs. There's quite a lot of pressure on the GP workforce, and we try to recruit more, but it can be really hard to recruit more. But we also know that GPs spend a lot of their time supporting people with non-medical issues. So we've introduced over the last few years an increasing number of roles who are specifically trained to deal with those non-medical issues through models like social prescribing and care coordinators. And that's something we've done as a partnership and thought through as a partnership. But certainly each of our individual services will be developing their own workforce plans to support ongoing and increasing pressure in those services.
Thank you,
Nina. Thank you very much. Sorry, Chair. Thank you very much.
No,
going forward, if we can have an impact assessment as we're going forward to see how all areas are meeting that kind of addressing issues in that particular area.
Addressing which issues, sorry?
No, I'm talking about impact, like doing assessment to see how the number of staff we have delivering the services that is being undertaken now in terms of the number of amount of pressure that they are dealing with. Am I clear?
Yeah, no, I think you are, and I think this is a question that this, as I said, I think this sits within the kind of responsibility of each of our services, and so each of the services will have resilience plans and business continuity plans in place. So they will have a detailed understanding of what the current pressures are on their services, how their workforces are able to meet those demands, and what their future workforce needs to look like to meet their future demands. And as I said, that work happens within individual services. So I'm sure we could. So yes, I'm sure that we have that on, but it will be across hundreds of the different services within City and Hackney. So it wouldn't be necessarily an easy thing to bring to this group unless there was a more specific service that you were interested in.
I think what I've got, it may be that, can I ask Councillor before, if there is a particular service that maybe if you could let Jonathan and myself know, it may be we can pass that on to Nina for a more honed response. I'm conscious I've got 4 people wanting to speak now. So what I'm going to do is ask the 2 people online. So Cllr Samatar and Cllr Adebayo, I'll take your questions together, and then I'll take the 2 members in the chamber, their questions together. So Cllr Samatar.
Thank you, Chair. I wanted to ask a question. I'm just looking at the report here. On page 23 is specifically on mental health crisis. And the part that says we want to support people at home as a safe alternative to A&E, and aim to have 90% of people refer to services within 2 hours. I just wanted to kind of get a confirmation of, is this already in place? Is it happening? Because reports are suggesting otherwise. And just before, sorry, because I was having connection issues at the beginning, I just wanted to declare for the record that I work for Mind in the city of Hackney as a network wellbeing coordinator.
Thank you, Cllr Samatar. We've got that noted now. Thank you. Cllr Adebayo, and then I'll ask Nina to reply.
Thank you, Chair, and thank you, Nina. Earlier on, Nina said something that I find very interesting, that there is some problem in recruiting GP. So, how do we break that particular barriers in recruiting GPs? And do we have any plan?
Cllr Adebayo, just on the recruiting the GPs, I asked Nina if she's got any observations on that. It may be something that came out of that Councillor Adams mentioned before in terms of GPs access and registration, that it may be at our January meeting we could ask for an update from primary care in City of Hackney to cover areas such as GP recruitment and access. So I think, and by all means, Nina, if she's got any contributions to make on that, fire away. But I think if we can on the recruitment of GPs, that may be, I think, a January item when hopefully we may be able to invite Kirsten Brown. So Nina, over to you on if you can assist with Cllr Adebayo and Cllr Samatar on the 90%.
So in terms of mental health crisis services, so what I was talking about earlier was really just the kind of tip of the iceberg of the kind of most acutely unwell people who are presenting in crisis and need a mental health bed. We also have a huge range of crisis response services in City and Hackney to support people who are in mental health crisis, including a 24-hour mental health crisis telephone line, crisis response teams, a crisis cafe, and various other community-based support. And the intention is to be able to respond to anyone who calls up in mental health crisis, is to be able to respond within 2 hours. And the intention is that, and for the most part, we do achieve that, but we are aware that we think there are more people that we think we could serve through those kind of urgent crisis response services. And we would also hope that by getting people into those crisis response services a little bit earlier, that you might then be able to prevent people getting to that point where they need to be taken in to an emergency department essentially and needing a mental health bed. So there are a range of, as I said, I think there are a range of good community-based crisis, mental health crisis services in place, and we think we have good provision around them, but we think there's more we can do to try and get earlier access into those services before people get especially acutely unwell and do potentially need a bed.
And do you have any observations on GP recruitment, or is it always best to leave this for Kirsten Brown?
Yeah, I think Curtis can answer this question better. We do, it is a challenge. We do okay relative to some other parts of London, but GP workforce is a national challenge. And there's lots of work that we do locally within the GP community to try and support our local practices, to try and make the kind of the GP role more attractive. As I described, some of that is around supporting GP practices to put in a range of other roles that can take pressure off GP specifically, to try and make that GP role more attractive and potentially put less pressure on our local GPs. But I think Kirsten can provide a more fuller and informed update on that when she sees you in January.
Thank you. Yeah, she doesn't know that yet. She doesn't know she's coming really to invite.
No, I think she'd be glad to.
Don't say anything just yet until we send the invite. Okay, so in the chamber, I've got Cllr Patrick, Cllr Adams. Cllr Adams, I know you have 3. Can I ask you to pick your best in a minute? Because I think we're running short on time on this item. Cllr Patrick first, and then I'll come to Cllr Adams.
Thank you. We've got good history in Hackney of thinking outside the box and using other people to deliver services other than medical staff where medical staff aren't needed, especially the voluntary sector.
Cllr Patrick, can you just move the microphone a bit closer to you? Sorry.
Sorry?
Can you just move the microphone a bit closer to you?
All right. We've got a proud history in Hackney, I think, of delivering services outside the box and thinking differently and using the voluntary sector. I am concerned about the funding of the voluntary sector, especially as budgets are tightening. Some of our acute hospitals are overspent. And I just wondered what the plans are. You talk about, it's some great plans here, but a lot of them are based upon using the voluntary sector, both skills and knowledge. And they do have skills and knowledge and can reach places that perhaps health professionals can't. I just wonder what the plans are to keep the voluntary sector on board, where we're going to use them, and also, more importantly, how we're going to fund them, because they can't do it without funding.
And before we just come to Cllr Adams, that's of course made, I think, more compounded by the fact I think the lottery funding that Hackney HCVS was getting is coming to its end to support some of the community services. Cllr Adams.
Thank you, Chair. My question is about the strategic priorities. We have 7 neighbourhoods, correct me if I'm wrong here. So I'm just thinking that how do the priorities, strategic priority, married with the priority of the neighbourhoods? So, I don't know if you get that, but I'm just thinking about the neighbourhood priorities, how they marry with the strategic priority. And the second one is that you talk about taking effective action to address racism and other discrimination. I'm just wondering whether you have any mechanism and how it's going to be monitored, and to know that you're actually achieving what you set out to achieve. And lastly, you talked about the Baffour ward. So at the moment, people talk about the pressure on staff in the ward and everything like that. So how the Baffour ward is going to work, and the quality of service, is it going to be affected because we have diverse community in Hackney where some people don't speak language, some people don't know how to use computers and everything like that. So I'm just wondering whether the quality of service for the Baffour ward is going to be a little bit different from the physical ward in terms of staff. Thank you.
Okay, Nina.
Okay, good questions, really good questions. I'll start with the virtual ward, just because that's on my mind. So I think essentially what we're looking at with the virtual ward is how you can take some of the kind of daily monitoring and daily rigor that patients, rigor's the wrong word, but the kind of daily rigor around monitoring patients that people get when they are on an inpatient ward, and how you can apply that to a community setting. So essentially, we're thinking about 2 cohorts of people. So firstly, we're thinking about this for very defined cohorts of people. So we will only consider this for people who really do meet the kind of set criteria, and we know it's safe for them to be cared for at home. And we're thinking about it for 2 cohorts of people. One, people presenting with frailty, who may need a hospital stay. And secondly, people presenting with acute respiratory conditions who may need a hospital stay. And essentially, people will be assessed. And if it's deemed to be safe, the model will be that they will be sent home, but will have twice or more, if needed, monitoring at home. And that monitoring isn't particularly digitally complex. It will involve either a telephone conversation, or potentially someone will be sent home with a pulse oximeter to measure their oxygen sats, if they're deemed able to do that themselves at home. But essentially the people will be checked in on a number of times a day by a clinician to ensure that they are still doing okay, and so to ensure that they are safely being looked after at home. So we wouldn't send anyone into a virtual ward without an initial assessment, and as I said, it would only be for those individuals where we feel comfortable that with some extra monitoring, either via telephone or in person, and it will be a combination of both, that they are comfortable and okay to be looked after in the home environment rather than going into a hospital setting. It's a new model of care, but it is an extension of some of our kind of existing community-based frailty services. So we're quite confident that we think it should be safe and appropriate for patients, and it doesn't rely on patients having access to digital equipment or kit. As I said, people will either be telephoned or checked in on in person in their homes. The discrimination, really, really good question. How will we measure it? And actually this sort of links to an earlier question about the voluntary sector. One of the things that we are talking about with our voluntary sector colleagues is how will we instill anti-racism in our commissioning approaches across the borough, and how will we measure that we are getting it right? It's not an easy nut to crack, but that's one of the things that we're working with our voluntary sector partners, and I think that's something I can bring back to a future committee with more detail around for you. In terms of the neighbourhoods priorities versus these borough-wide priorities, again, it's a really good question. So we have 8 neighbourhoods within City and Hackney. They are absolutely part of the City and Hackney place-based partnership, and they will absolutely fit within this the kind of things that we're doing within all the neighbourhoods, and the things that are happening within all the neighbourhoods are absolutely part of these broader borough-wide strategic focus areas. But there will be different levels of focus on the different population health cohorts within the different neighbourhoods. And that's the beauty of neighbourhoods. It allows us to do that. So, for example, we know that in the north of the borough, where we have more children, there'll be more focus, attention and resources into thinking about supporting the children's elements of the plan. And also we know we've got lower rates of childhood vaccinations and immunisations. So that element of the kind of broader plan will be a much bigger focus and focus for the neighbourhoods in the north of the borough where there is a younger population. Likewise, in the city, in the Shoreditch Park and City neighbourhood, particularly in the city where we've got a much larger older population, there'll be more focus and attention on the part of the thinking about how to support people with long-term health and care needs. So I think we're all part of the bigger strategy, but the neighbourhoods approach enables different parts of the borough to take a more localised focus and attention depending on what their local population health needs are and what their local demographics are.
Thanks for that, Nina. In terms of Councillor Patrick's sort of more fundamental one about the resources behind the voluntary sector, are we be able to say anything more on that?
No, I think that's a really good question, and that's an active challenge that we all are grappling with. So as a partnership, we're absolutely focused to supporting our local voluntary sector, and we see them as key to driving some of our more tricky challenges around health inequalities and population health. And I think they hold many of the solutions around really thinking about tackling entrenched health inequalities, particularly when you start thinking about people's economic well-being and social connectedness, which are 2 of our strategic focus areas. We are actively thinking about how do we support the voluntary sector to engage in our system. So we have a VCS enabler, which essentially funds infrastructure within the borough for the voluntary sector to be able to come to the table and help us find solutions and think strategically about what we need to do. And we are continuing to work with the voluntary sector. We are committed to making sure that the voluntary sector can still engage with us and really be part of our system and engage with us in finding solutions. We also have access to some health inequalities funding from NHS England, as well as a small amount of prevention funding that we hold locally. And we're actively really thinking about how we can make sure that that funding, as far as possible, supports the voluntary sector, and really thinking about how we prioritise the voluntary sector for access to pots of money like that. We do also challenge ourselves to think about where we commission services, which of those services actually should be provided by the voluntary sector, and really thinking quite proactively about where we can think about the voluntary sector supporting, either in delivering a whole service or partnering with another service provider to support improved engagement and outreach from that service. And we have many voluntary sector organisations that currently do provide really, really vital services for us in City and Hackney that we absolutely want to continue to work with.
Thanks, Nina. I'm going to, I think, draw this item to a close now because we've overrun on it. In terms of things arising, I think when the outcomes framework is more developed, are we talking maybe March, April time? I don't know.
Yep.
And that may dovetail with, say, some of the questions Cllr Adams was asking about how we monitor or embed preventative racism within the system, and we can actually look at that in more detail and actually just understand how you're testing yourself with respect to that. So that it may be that we return to that when we've got the outcomes document, but we can actually look at that in a bit more detail, and we can take some sort of case studies from. In terms of what's going to the HCB, those two papers, will they be in the public domain, Chris or Nina, or not? Or are they internal?
So it's a development session, so it's not a public meeting. Yeah, we can find out at what point they can be put in the public domain.
Fine. I think what I'm thinking is just to let you know is more for the INL meeting in a few weeks, whether something akin to a framework of that could be presented. But that's maybe something I'll take this. Yeah, it may be we have to pick that up elsewhere. Okay. With that, then I will close that item. Thank you very much, Nina. That's an hour-long session from you, so thank you very much for your time. I'm now going to move on to the next substantive item, which is adult social care and the fair cost of care as it's been badged. We're joined again by Helen Woodland, who's the Group Director, Georgina Diba, who's the Director of Adult Social Care, John Holden, who's from the Finances and Resources Directorate, and also Zainab Jalil, the Head of Commissioning. In a nutshell to members, this is obviously a government plan to raise the level at which citizens or residents have to contribute towards their care to around 86,000. As I understand it, Jeremy Hunt has put that implementation to 2025 from what was due to be 2023 next year. But I'll hand it over now to Helen. Again, did you want to say anything to start with, or maybe hand over to one of your colleagues?
Yeah, I'll just do a very quick introduction because hopefully members can see there's an awful lot of work been done on this, and there's quite a lengthy report there which hopefully people will have read. So my thanks to the team in the first instance who have been doing the work. As you say, the date of the implementation of actually implementing the reforms has shifted.
Sorry.
Oh.
Hi, Nina. Are you still on? Do you want to mute your microphone, Nina?
Oh. Okay.
He's muted.
Good, thank you. So there is still some uncertainty around exactly both how much funding local authorities are going to get, when we're going to get it, and how exactly we need to use it. So we've continued with our planning regardless, because we know that funding is coming, and we also know that we need to support the market, and we also know we need to be prepared for these reforms to come in. So as a context, that's probably all I wanted to say, and I'll hand over to the team if that's all right to give a bit more of the detail.
Thank you.
Hi, so I'll start. So I'm Zainab. I'm very sorry if my screen's not going straight. I apologise for that now. Thanks. So the presentation largely describes the work we've carried out to look at establishing and setting a fair cost of care to our providers. So in the slides that Helen talked about, we start by setting the scene. So that's slide 2. We talk a little bit about the statistics, and it just shows you how important spending adult social care is to the council and that our need is growing. If you go to slide 3, we talk about the fact that in September 2021, the government set out plans to reform adult social care in England, identifying 5.4 billion for plans. It included 1.4 billion to help local authorities to move towards the fair cost of care. But then the budget this November 22 stated that the work was being paused, as Helen talked about, for at least 2 years. The areas for reform was the cap, as you outlined, where no person would pay more than 86k, and then also, as described on slides 3 and 4, that a person could ask their local authority to commission their care, which requires us as a local authority to ensure there's a stable market and fair rates for all. In the next few slides, we talked about what we did to engage with the market and what we found out. We've kept some of the figures out because it's got commercially sensitive information, so we haven't given all the figures here. I'll just refer to slide 5 for John. Do you want to just talk to slide 5, John?
Yeah, so this slide 5 was trying to show, you can see in the background in the white part that it was showing what we were expecting to happen. So it's the 5.4 billion.
John, just to stop you there, this is just the members are with us. This is the slide that says national breakdown of ASE reform funding. Is that right?
That's right. Yeah. Thank you.
Yeah. So sorry, let me just show members in the chamber. So it's that slide there in the pack. Okay. Right. Sorry, John. Start again.
Yeah. So this slide tries to show you what we thought was going to happen and the funding that was going to be attached to these reforms. So the 5.4 billion, and then as has already been mentioned, at the end of November, a number of this funding has been changed, and some of it has been repurposed and will form part of an overall social care grant, rather than being specific for supporting providers with this fair cost of care. So far, the only real information we do know is what we've received this year. So within 22-23, we received 948,000 as a start towards this exercise. But funding for next year and the year after that we were expecting is currently uncertain as to how it will actually come to the council and whether any of it will still be badged towards cost of care or whether it will be wider funding to support the overall social care sector.
Just before we move off then this slide, so just taking it through, the 5.4, because we've got this on our pack, we've got this sort of blue box. The 5.4 was the 3.6 billion in the first bit of the table plus the 1.7 that's sort of been covered by the blue box. Is that right? So what can you just explain, what was the breakdown between the 3.6 and the 1.7? What was that?
Well, 3.6 was overall funding for the care charge reforms, and the 1.7 was other reforms and was mainly workforce training type reforms. So the monies that have been announced are within those two pots, but the focus that we were looking at really was the 1.36 billion that's in that slide. That was the money that they had grouped towards the fair cost of care. But when people talked about it, they often referred back to 5.4 billion. So I've tried to sort of show how those bits were put together. But fundamentally within that, it's effectively all been repurposed. And within the numbers that are there, you can see against 1.36 billion, you can see 22-23, 162 million. And that number was given to all local authorities, and Hackney's share of that was 948k. So we were expecting 600 million next year, 600 million the year after, but they are the numbers that have all been repurposed and will not necessarily come back in the same form next year.
And so the 948,000 that Hackney has and or will get, if it's 22-23 has got, what's that? Is that seed funding essentially to embed this new system and work out how it works, or what, or not?
Yeah, there is a slide later on in the pack that shows you how we've allocated that. So the 948k was a mixture. 25% of that 948k was potentially for internal use, to do this entire exercise and communicate with providers and work with them and do the analysis. And then 75% of that 948k was to be given straight to providers. And it's still our intention that we will give that money to providers to support uplifts that we've got within this financial year. So our aim is, again, it's a grant we've received. We will spend that by the 31st of March.
And so just to be clear, even though, and just to assist members, the breakdown John's referring to is that page there with the two different colour slides. And so if I understand, I just understand, so even though fair cost of care won't have come in, and so the new 86 threshold won't have applied, it's still the intention to give that 75% to the providers, essentially in recognition of all the cost pressures they are under at the moment, which we could list for numerous reasons. The sector's already significant problems, inflation, energy costs, etc. So it's already, so irrespective of this cost of the 86,000 being implemented, we're going to passport that on because we recognised our need to support the sector. Is that right?
So that funding will be passed on to providers. 75% of that 948k will be passed on to providers as part of this grant. So the sustainability grant that had conditions that we had to pass that on.
And so maybe Helen's just put her hand up. Helen, can you just while we're on this, before we then, sorry, I've diverted off, but I just want to understand this. Are there any conditions attached to us giving that to the different providers?
So it's worth remembering that the entire exercise around fair cost of care was in recognition that the market is charging self-funders more in order to balance out the costs that they're incurring for what the local authority pays for their clients. And that hasn't changed. In addition to that, they've got significant inflationary pressures. And as you've said, Councillor Hayhurst, there's a number of factors that have meant that our market is at risk, I would say. So not specifically within Hackney, but in general in the country, there are areas where the provider market is particularly shaky and that local authorities are seeing closures. To be really clear, we haven't seen any closures or anyone giving any contracts back within Hackney. But we are very aware that actually the costs that the providers are incurring and the demand that they are seeing is increasing. So we need to find a way to work towards that fair cost of care with the funding that we know we've got in preparation for when the reforms do come in.
And just being, just before we go back to the rest of the presentation, just being cynical for a minute, or sort of on a due diligence point, what's our assurance, or what's any local authority's assurance, if that's 162 million that's been given, of which 75% goes to providers, that say a private provider doesn't just retain the same quality of paying its staff and essentially the rest goes in profits or dividends or what have you? I mean, what assurance or safeguards are built into the process to make sure that either gets passed on to staff through cost increases or goes to building capacity and all of those things?
So it depends on the local authority area. So there are no national restrictions on it having to be passed on to staff. Bearing in mind that most markets, most local authority markets will have a significant number of private providers in them. In Hackney, actually, we don't. We only really have one. The majority of ours are charities or social enterprises, or actually one is an NHS provider. But that being said, the kind of safeguards you're talking about are held within our commissioning and contract monitoring. So we have a very good relationship with our providers. We already are a London living wage employer, and we use our contract monitoring and our commissioning in order to ensure that our providers are paying that London living wage to the staff that they employ.
Thank you. So sorry, back to John. Did you finish your segment then on the finance side?
I finished on that slide yet. Zainab, if you want to continue.
Yeah, so if you go to, I think it's page 34 in your pack, so slide 6. This slide illustrates the products we were required to complete by the Department of Health and Social Care. So we had to establish a set of rates based on what our market was telling us, the intelligence we had. We interrogated this, so John and other members of our team were a key part of that. And this was for both the care home market and for home care market. We had to produce a spend report of how we plan to spend this year's grant allocation, which we'll look at a little bit again, and we've already talked about. We had to explain how we engaged with the market and how we asked questions and what we did to corroborate the findings. We also had to produce a market sustainability plan, looking at legal, technical and other factors that were impacting the market. So thinking about need as well, thinking about future modelling. So all these documents have been submitted to the department and they're sensitive at present, so we're waiting for their feedback. The next slide called Summary of Returns, and then the summary of the annexes. This slide shows a summary of our returns, and I wanted to highlight that over 80% of our spend in home care is represented in our conversations with providers. We try to segment the providers by micro, small, medium and large, and think about the different types of providers. We also think that one of our findings was that we think it's easier to set up a home care organisation in Hackney. There's less capital costs, for example, and we found this industry is slightly more stable than the care home market. So the care home market was a bit harder to understand. We've got fewer care homes in Hackney. Again, though, our research covered about 80% of spend. In this market, we're reliant on our neighbouring boroughs. We don't have enough supply for the demand that we have. So working, especially in the Nell area, is key, and we've started talking to our Nell partners about that. We found with care homes in particular, our local providers reported that they were unable to make profits, and the number of self-funders, which Helen mentioned, cross-subsidises care, is very low in Hackney. If you go to, John, I don't know if you want to add anything to that, if I move to slide 9.
No, just that we were pleased that our returns gave us what we felt like was a reasonable sample of people from the home care providers. Care homes, we have very few care homes in the borough, and so we had a much smaller data set to look at.
Okay, thank you. So slide 9, I think 37 in your pack, just provide some of the feedback from providers, some of the issues they're facing. So recruitment and retention has come up a bit. Staffing is a big issue in many different ways. Lower salaries, obviously, other areas like supermarkets to compete with. The status of the job is also very important. The way some providers use 0-hour contracts, a lack of career progression, and ethos of independence is really important for us in terms of the service that we want, and that's always not always being carried through in terms of the contract, in terms of the service from the provider. Cost of living, fuel, energy, all those things we've already talked about, and the role of cross-subsidising. So lots and lots of different factors, lots of intelligence to help us think about how we work with the market. So a really good exercise to work with providers on. Slide 10 just highlights the, is it slide 10? The next slide highlights the methodology we used, directed by national government. So we used the toolkit from national government. A few local authorities chose not to do that. We chose to do that so that we could compare data and build up a stronger intelligence, especially, again, as I said, with our Nell markets, and especially thinking about care homes. So we don't have enough supply, and thinking as well about limited funding and how we can work well together. In the next slide, slide 11, we've been clear that funding is limited with all of our providers, and we've been clear about that from the beginning because we didn't know how this initiative was going to shape up, and we thought that the grant may not be enough to for all of our aspirations. We've been clear that our ambition is to travel towards the rate, and we're also keen to explain how we've done that to the market to try and be fair and transparent. And linked to this is also our work that we do every year on standard inflationary costs. The next slide, slide 12, tells you about our plans to spend the grant so far. So we've really chose to think about how we can support providers with pay as the main issue. And then again, John, I don't know if you want to highlight anything here.
No, this just gives a breakdown of the sort of 75% and the 25% and how we've utilised this year's funding from the sustainability grant.
Thank you. And then the final slide in the pack is just sort of letting you know that we did submit our returns on the fair cost of care on the 14th of October. Then we had the budget announcement. We're still in conversations with the department to find out what exactly they want us to do next and how they're interrogating the data. So we're still thinking about implementation, but we're waiting for more guidance. I'll probably end there, and I don't know if there's any questions.
No, thank you. So just to understand it, so if, just to try and understand the overall picture, if then the implementation of the proposals got pushed back to 2025, this links to what John had said. So the 162 million, which is on page 33 of our agenda, has already been given out to the local authorities. Hackney's share was 948. At the moment, the 23-24 money and 24-25 money is being repurposed. So we'll have to see what happens then if this does take place in 25, and whether we receive enough funding, if I'm getting this right, to actually make it work and viable from a local authority position. But for a minute, let's just assume that the modelling that you had done and what you had highlighted in red, I think on page 38, to say the funding from government is unlikely to match the cost of care rate generated by the toolkit, which was your modelling. How much, assuming the 23-24 figure and 24-25 figure of 600 million, as Hackney, how much below on that modelling would we have been? How much does that impact? How much would that have impacted our general budget position every year, roughly speaking?
I can try to answer. I mean, at the moment, it's very difficult to say, partly because the government were consulting on the methodology to distribute the 600 million. So we got £948,000 this year against the 162 million. We don't know how much they would give us next year. And we're not going to know now until they restart the whole process. So it's very difficult to then say how much it would be in terms of an absolute number. But what is very clear from the modelling we did do is that the costs that we generated were quite significantly in excess of the funding that was available. That data has been passed to the department, so they should be aware as well of the gap between what our average rates were and what the modelling then proposed, and should then have that from all councils so that they should be well informed about how potentially any additional funding would then be distributed. But nonetheless, I think it's key to note that I think it wouldn't be sufficient. And that's why we have emphasised that slide about whatever funding we would receive, we would work to pass that on to providers so that we work towards these cost of care rates.
Thanks, John. I mean, did you just do any rough modelling that if we got the same percentage of 948 over 162, if we got the same rate over the 600, how much would we have? What would have been the gap?
We did some simple modelling like that, and then we did some exercises about how we would distribute that model, taking that exact assumption. If we got 948 against 162 million, how much would we get against 600 million? But the numbers that we were generating with our modelling were again in excess, way in excess of that available funding.
Councillor, I'll bring Cllr Kennedy in now, and then I see Councillor Samatar with a question. Cllr Kennedy.
Just a very quick point I can't resist making, Chair. Do the maths on the electoral cycle. When does the real pain of this hit? It hits after the latest possible date for a general election. And this isn't the only area in which we are finding that actually the recent financial decrees of this government have actually cost shunted stuff for 2 years. Thanks.
Thanks for that perspective. Councillor Samatar?
Thank you, Chair. Before I ask my question, I'm really sorry I didn't tell you before. Can you just add to my declaration that I'm also Vice Chair of the Hackney CVS LGBTQIA Steering Committee?
So thank you. Thanks for noting that. Did you want to ask a question as well?
Yes, I did. And
Off you go.
I had a kind of a two-parter, a general care home kind of a question, which is, what role do families play in how we are shaping the structure and the frameworks of when we're thinking about the kind of care homes that we need to develop to provide adequate care? What role do families, particular parents, play a role, and if there any? And secondly, I wanted to know what is more needed at the moment, a new council-owned care home or a new council-owned intermediate care facility, and if the team can explain why either is better than the other.
Helen, do you want to go for that?
Yeah, I was going to make another point, but yes, I'll happily address the question as well. So to your point previously, Councillor Hayhurst, just for, I suppose, people's information, there was a Lang-Busson report that looked at the difference between the funding that was originally proposed and the funding that would be needed nationally. And it was a difference of 2/3 more they were proposing. So that gives you a kind of idea of the scale of the difference between what local authorities are saying the market needs and the original funding that was proposed. Councillor Samatar, in relation to your question, so we don't develop care homes, and we have no plans at the moment to develop a care home. What we do is work very closely with the market around the types of care and the quality of care that's received. And we would want families to be heavily involved in all of that. Our biggest challenge, I suppose, is, I think, as mentioned by Zainab, about 68% of all of the people in Hackney who go into residential or nursing care actually go into homes that are not within Hackney at the moment, because we have a very, very small market. I think it's probably not necessarily helpful to compare intermediate care with long-term residential care, because they're very different things and are used for different purposes. We do have what we call step-down care available through our Housing with Care scheme, which is to support people coming out of hospital and then hopefully get them back to independence. But I think when we're looking at long-term planning and what we might want to develop or invest in Hackney, we would probably prefer to look at different forms of supported living or extra care supported housing, because we would want our residents to be able to live as independently as possible, and having more of those kind of options for a wider range of residents over different age groups, I think would probably be more helpful to us than developing more residential care.
Councillor Patrick and Councillor Adebayo to come in, but just on that, Helen, so it wouldn't, so say fair cost of care is implemented and local authorities under enormous cost pressure, would there be a financial case to, you might not have the money for it, the capital funding, but would there be a financial case for in-house provision because that would be cheaper? Or actually, even if that was the case, you're not actually sure because of all the pressures on the sector, actually in-house provision would just not necessarily from an affordability perspective, not actually solve much.
Yeah, so I mean, we wouldn't rule out looking at it, but probably not because, from a cost perspective, purely from a control of nomination perspective. But I don't think from a cost perspective we would necessarily look at developing our own in-house residential provision. Bear in mind, one of our residential homes in the borough is actually run by the Homerton anyway, so they're an NHS provider.
Thank you. I saw Councillor Patrick next.
Thanks. How are you working with partners, other boroughs? Because most of our care homes are not in Hackney, and the ones in Hackney are leaders we're working with. So how are we working with other boroughs to look at the market across East London if we're placing most of our residents outside. As I heard what you said about that we didn't need to develop a care home and about more intermediate care, but that seems to have gone on the back burner over the last few years. We did have a time when we developed quite a bit of intermediate care, but I don't think we've developed anything recently. I have heard mutterings, I think, both from yourself and from Cllr Kennedy about restarting the programme. I just wonder whether there's anything positive to report.
You want to take that, Helen?
Yeah, sure. So we're working very closely across NEL, and Zainab is working with her team as part of a NEL commissioning group. So we bring together all of the local authorities in NEL to manage the market that way. Apart from anything else, Councillor Patrick, is a really good question, because obviously how different local authorities choose to use their investment has an impact on the overall market. So what we wouldn't want is a position where Barking and Dagenham, for example, is moving more quickly towards a fair cost of care than we are, which destabilises the market in general. In terms of intermediate care, actually we have developed, and we do every year, a number of different intermediate care options as part of our winter pressure funding and planning. So we have a range of beds that we commission to support flow through the hospital over winter, and we increase the number of step-down flats that we can use through the Housing with Care scheme. I think the longer-term plan to look at capital investment and building around supported living, that's something that has been very firmly put onto the agenda with our housing and our regen colleagues, and Councillor Kennedy has been very vocal, as have I, in advocating for that. But I think it has to be part of an overall asset management development strategy where we look at what investment we have available and where we choose to invest that. But those discussions are absolutely ongoing.
Councillor Adebayo?
Oh, thank you. Earlier on, Ellen said that we have very small market in terms of care and supported living. I'm just wondering, what are the barriers that we are currently facing in Hackney that is stopping us or preventing us from expanding? In terms of supported housing and clearly, you know.
Good question, Councillor Adebayo. Hackney in particular, the barrier is land and cost. So if you were going to attract providers, private providers, to deliver or develop care homes, or even supported living in the borough, you'll have known from conversations around our demand for housing in general. We're quite a small borough geographically, so being able to build is dependent on having somewhere to build, but also the cost of land and development in Hackney is quite significant. So if you are a care home provider, it is cheaper and therefore you would make better profit if, for example, you built in Havering or in outer northeast London. That doesn't mean that we shouldn't look at it, and it doesn't mean that we can't look at it, but it does mean that we probably have to think creatively about attracting kind of registered providers and development partners to be able to do that in the future.
Thank you.
And just so I understand, your comment about, to Councillor Patrick's question about needing to work at the same pace as other local authorities, so one doesn't destabilise the sector of the other. I'm just trying to understand that. So a way to understand that might be to say that if, say, another local authority was suddenly paying more for its placements to, say, a provider, then of course that provider would be more readily to take places for that local authority, which would be at the disadvantage of the others. So it's important that you all work together on what you're paying, so that in a unified fashion, So is that, yeah, and then I suppose this is perhaps helping me understand really about that, the 75% of the 948, because in a sense, is that actually just trying to increase, because as I understand it, per person per week, local authorities would pay about 700 for an individual, whereas a private place would be about 1200 or so. Is it, roughly speaking, I mean, is it the case that some of that 75% then was just trying to slowly raise the amount that essentially the local authorities essentially were paying, just to try and sort of get it more towards parity?
Yeah, that's exactly right, Councillor Hayhurst. So if you think of, we make a lot of placements in Havering. So if you think of a care home in Havering, it might be quite large. They'll have placements from Hackney, from City, from Havering, from other neighbouring boroughs, even from Essex. If we are all paying different amounts to the provider and increasing what we give them at different rates, the availability of those beds will, as you say, go to the people who are willing to pay the highest, and we end up creating a kind of competition where we escalate prices, kind of a false inflation competition, which isn't good for anyone.
And then sort of really drilling down into Councillor Patrick's question, I mean, is it the extent that there is a really good understanding against the sort of 7 or 8 local authorities that it's important to abide by that principle, or are there sometimes tensions within that?
There are absolutely tensions, because you're also responsible for maintaining the quality and stability of your market within your own borough, and different providers are reporting different types of tensions and asking for different levels of inflation. So getting 7 people to agree to an inflationary increased rate when we don't have certainty over the funding available to do it is always a tension. What there is a really strong commitment to work together to try and resolve those tensions, including a long-term kind of commissioning fair cost of care group, so that we meet on a regular basis and talk about how we can do this in a fair and sustainable way going forward.
Councillor Adams, then I think I'll wrap this item up. Councillor Adams?
Yeah, thank you, Chair. Yes, at the bottom of page 37, it's stated that the providers subsidize LA users with private fees. Once the cap is introduced and private users' fees move to the LA rate, income will drop. So what will happen to the market? Will the market bust, or what's going to happen to the market if that happens?
So that's one of the risks, and that's why how we implement it is very important. What we hope is really that we're standardising the rates so that one group of people is not paying more unfairly for the same quality and type of care. I think we have to be really clear that the market in general, the social care market, both in terms of residential and nursing and home care, has significant challenges, not necessarily helped by the cost of living crisis and inflation at the moment. But I think more important is for us is having a really clear, sustainable long-term funding solution for adult social care. At the moment, we can't give a surety to our providers because we haven't been given it. So they find it difficult to plan. We find it difficult to plan. That increases the risk and the uncertainty in the market. And this has been happening for quite some time. So the instability in the market, I think, probably would be best addressed through a real, genuine, long-term, sustainable funding solution for adult social care.
So thank you. So just trying to wrap up with just trying to get a grip of where we are undoubtedly. So that the real tension point, which would have been the immediate introduction of, say, the 86,000, has been postponed, may end up being after the election. So that immediate tension has gone, been postponed, but that doesn't relieve all the existing tensions that were existing in the sector, and that the sector is struggling for the reasons you've indicated. We're struggling to give stability to it. And that's currently exacerbated by all the inflationary pressures as well. So it's not, albeit the crunch point has possibly been delayed, That doesn't mean that there's still not day to day, week to week incredible pressures across the sector, which we're dealing with. So that's where we're up to at the moment, and you're not going to know any more as to how the fair cost of care will be implemented until there's a financial proposal, which presumably will now be much later, nearer 2025. Is that the rough version of the land? We're not expecting anything in the next year or so now that will further this debate. Is that right?
So I think we are awaiting more immediate guidance because this funding runs out in March. So we will have to know what's happening next year, because it can't just stop. So even though you may not be implementing the wider scope of the reforms, the issue is still there and the funding gap in the market is still there. So it may not be a long-term solution, but I would expect that we will get some kind of guidance and some kind of agreement on an investment settlement, for want of a better word, for at least the next year. We were hoping in the December statement. Whether or not that happens, I think we'll have to wait and see.
I've got it right. That essentially, that 75% of the 948 was really just needed to essentially keep the market afloat. Yeah. Because if there wasn't and that wasn't reoccurrent, that was just a one-off for that year. If there is not something similar, there's a significant concern of market collapse, particularly with all the pressures that we're seeing elsewhere. So hence, there needs to be possibly another sticking plaster, yeah, until a more longer-term solution's met, if I've understood it.
Absolutely.
Yeah. Okay. Okay. Thank you very much for that. That's a very helpful update. I mean, just now that we are now helpfully more up to speed on this, I think when you do know about what the financial assessment is for next year, I mean, it would be just now that we're more up to speed, it would be helpful just to be informed about that and where we are, just so we can keep more of a constant understanding on the issue and the build up, possibly to 2025. But thank you for the very helpful presentation and the work that's gone into it, and for you all coming today. That was very helpful indeed. So I am going to close that item now and move to our last substantive item, which is the implementation of the what was the DOLS. I think they may now be called Liberty Protection Safeguards, if I've understood it correctly. And we are again joined by Helen, Georgina Diba, Director of Adult Social Care, and also Dr. Godfred Boahen, who's the Principal Social Worker at Hackney. Welcome. And you are going to give us a brief update on the change of these safeguards. The last time we spoke, Helen, I think you were waiting for updated regulations to provide more guidance. I think that may now have happened. I don't know, but and the coming in force date of this, I think, is imminent, if I've got this right. So over to Helen. Do you want to give a brief introduction again, or over to?
Yeah, very, very brief, because Godfred and Georgina are the ones who've done most of the work on this. So as you say, another piece of legislation that was brought in and postponed repeatedly. We now do have more information and a timeline on when it is coming into effect, and therefore Godfred has done a huge amount of work to prepare us and our wider partners for it. So if it's okay, I'll hand over to Godfred to give you a summary.
Yes, thank you so much, Helen. I think what I'm going to speak about now picks up some of the themes from the earlier conversation. As you've said, Helen, we know that this is a really important piece of legislation which has been in discussion for decades now, and it really goes to the heart of how society, local authority professionals look after people who need care and support and protection, but who do not have the mental capacity to consent to that, and also the sort of values and safeguards which should really shape the work that we do with our citizens who need that type of support. So just to, by way of some context, we go back to the enactment of the Mental Capacity Act in 2005, which stated the legal framework by which we assess capacity of people to consent to their care and support needs. This was then amended with the Deprivation of Liberty Safeguards, which charted a legal framework to deprive people of their liberty for their care and support. Then fast forward to 2014, an important Supreme Court judgment about what constituted a deprivation of liberty safeguard, deprivation of liberty, my apologies, which then made the sector realize that actually that threshold is lower than previously thought. It led to an expansion of referrals and demands for more authorizations. The system was felt to be overly bureaucratic and had to be simplified. And so the government initiated a consultation via the Law Commission, and the Law Commission then made some proposals which we're calling the Liberty Protection Safeguards. The main aspects of the Liberty Protection Safeguards is that it increases the range of settings in which authorizations apply. So in a sense, it will make the system simpler, because those authorizations can be carried from one setting to the other. Also, it increases the range of statutory organizations that can also make authorizations, and NHS bodies are included in what will be called responsible bodies who can authorize those deprivation of liberty for care and support. And importantly, it also extends the remit of this to 16 and 17-year-olds. And then finally, it simplifies the process by reducing the number of assessments which are required. But we know that these reforms are coming. Sadly, we do not know the exact date of implementation, or even the final code of practice is still subject to consultation, which the government is analyzing the feedback of that consultation and would then let us know the final sort of code of practice and the frameworks that would govern that. So amidst all that uncertainty, we're having to plan, thinking about, if you like, some fundamentals which we think the LPS scheme would need to follow. However, this is also within the context of, workforce shortages, which we know have the reasons for this are well rehearsed. We also need to think about the involvement of all our partners within Hackney, so that whatever scheme is designed would be seamless, and people that having care and support needs would experience a seamless package of care. So we've done a number of consultations with our staff in Hackney to develop the scope of what a model might look like, subject to further confirmation of the details from the government. We've also worked with our partners, including the Trust, the Homerton, the ICB, the ICS, and also Children and Family Services to start thinking about what a model of LPS might look like in Hackney. But it's important that this work is underpinned by some really important principles and values, and one of which is to recognize the unique demography of Hackney, so that the LPS model which we implement here responds to the cultural needs of our residents, and at the heart of it also is co-produced with residents and advocacy groups and also providers. We take a whole systems approach, as I mentioned earlier, so that the experience of care across different settings is as seamless as possible. And importantly, we also underpin this with human rights principles and really high quality professional practice, so that our care and support provision is legally compliant and also responds to the particular requirements of the LPS. So between January and March next year, we hope to do some further work with our providers and also residents and advocacy groups to really finalize the model of LPS, which we would implement in Hackney. We also want to train the workforce, because we've seen LPS as a really important opportunity to scale up the workforce in delivering care and support, which is compliant with the Mental Capacity Act. And so we'll begin that program of training next January to March. And then we also want to work with our partners across the system to develop a clear care pathway to enable that care to be seamless for people receiving care and support. Thank you very much. I'll now take some questions.
Thank you, Godfred. That's very helpful. I had two. With the expansion of responsible bodies, to what extent is there a risk that once you take the responsibility just away from one body, say the local authority, to many, that people actually fall through the net? Or what procedures do you put into place to make sure someone is carrying ownership with respect of any specific individual? And also, just why, I suppose, why would, say, for a resource-strapped NHS trust, why would they, to be crude about it, volunteer to undertake this responsibility when it could be done by the council? So how does that play out? And so there's that aspect about the responsible bodies, about how it will play in practice, and people slipping through the net. And the other question was in terms of the expansion of settings. And again, I think it may be a simplified example, but when I previously understood dolls, that would be in a situation where someone essentially is deprived of their liberty. So normally in an institutional setting, when they say can't leave for whatever reason, but now if the settings are being expanded to the home environment, how does that work? Is there a lesser form of deprivation whereby they still have means of freedom, but less? An individual may have less, doesn't have capacity to make certain decisions over banking or finance or things like that, but they would still have freedom rights, as it were, and so that's how it can still work in a home setting.
Yes, thanks very much. I think it's a really important question about the falling through the gaps, and I think that's why it's really important that we take a whole systems approach within Hackney, so that as a system, we've developed clear pathways to ensure that we can capture movement from one system to the other, so people don't fall through the cracks. And then secondly, in terms of why different responsible bodies would want to fulfill that requirement, the expansion, fundamentally it's now their statutory duty to do so. So part of our work as a local authority as well is really to offer some leadership within the system to really explain what those new legal requirements are and the expectations of responsible bodies to fulfill them, and also meet those requirements in terms of the care and support provision, and also the provision of professionals who can undertake the liberty protection safeguards work.
Just on that point, Godfred, so an example would be if somebody is in the Homerton, and for whatever reason there hasn't been a liberty protection safeguard order previously, but the doctors are of the view that one, say, is appropriate. If it's their, say, professional opinion, the statutory framework would therefore mean that essentially that institution, that hospital, is then the organisation that carries it through, over than saying, referring it to Hackney Council. If their medical professions have certified that in their view, they've got responsibility for it. Is that right?
That's correct. And the one advantage of the LPS is that if we do some careful care planning, it would mean that the authorization is portable. So we wouldn't then need to replicate and duplicate the assessments which have already been done within one setting. That care plan can move on with them within into a different setting as well, say for instance, a care home.
In terms of my second question about how does the liberty protection safeguard work in the home environment, can you just give maybe an example as to how it would function in that environment, if I've understood it correctly, that you can have it in the home environment?
I have to say that the details of the precise application of the LPS is still being finalized. The government has the code of practice is not very clear about what is a must, what is a should, and what is a may. So we're just having to work through the details of that, and hopefully further details will be forthcoming from the government when the consultation process is analysed and the details finalised.
Okay, thank you. Members, any questions? Councillor Patrick.
Yeah. How do you see it working with 16 and 17-year-olds? Obviously, 16 and 17-year-olds have rights to advocate for their own healthcare in some instances, but also legally, in some other instances, they're still children. So, and also families would presumably want to be involved. How do you see that working out?
That's a really important question, and I think that's maybe one of the real challenges that we need to keep an eye on in terms of the implementation of the LPS, because up to now, the process has been an application to the Court of Protection, which can be adversarial, it can be costly, it can be lengthy. So we now have to work with our colleagues in children and families to really enable them to understand the full implications of what LPS means. And it would mean, for instance, revisiting some care plans to then have a scoping of the range of young people who the LPS will apply to, and then making provisions for meeting their needs. So it's really a case of, I would say, doing an audit now, using the new LPS standards to then get a sense of who that might apply to in children and families, and making provisions.
Councillor Patrick's question is just, Georgina, do you want to come in there?
I think on that, I would say is that under the current arrangements, families, parents, anyone who's supporting a young person or a child, they would be involved in that decision making, and within the LPS that will remain. So I think the important thing to think about is when we're helping to make a best interest decision around a person who lacks capacity, we always consult with those who are involved in their care. So that won't change really. But I do think, as Godfred has mentioned, with the shift to the LPS and moving that out of the court arena, there's a better environment in order to work with parents or caregivers in a different way. I think it could really help to strengthen that relationship and more about a partnership approach with the young person at the centre.
And just to understand this though, so previously with 16, 17-year-olds, there would have been a mandatory court of protection process, whereas with LPS, it's a at its first stage, it's a non-court process, but presumably a 16 or 17-year-old, either through themselves or through their guardian or advocate, would still have a fallback of being able to challenge it through a court or tribunal. But whereas the court of protection was almost a fundamental part of the process historically, that is then being removed. Yeah. So I suppose you could cut this in different ways. You could say in some ways you're getting less legal safeguards, but seeing it through another prism, it's taking it out of the courtroom environment.
I mean, I don't think the words are going to reduce, because actually the work that you're doing in advance with people in the LPS around capacity, around choice, around least restrictive, means there are still a huge amount of safeguards in terms of advocacy as well, huge amount of advocacy and support. and it's definitely not reducing the ability for people to challenge, which they currently have, and to have someone kind of on their side in that advocacy role who can help them to do that, where they might struggle to voice that.
Thank you. Members, any further questions? I don't see anyone. So then, where we're up to then in implementation, as I understand it, from what Helen indicated at the start, and from I think what you said, is that we don't have yet, because we're waiting for the further details in the code of practice. We don't yet have still an implementation date, but you're as far as you think you can be in preparatory work without the specificity of the code of practice. Just briefly, there was something, I think one on the slide deck, you used the word slightly as a description to say how much more that would increase our resource implication. How confident are you with the use of that word slightly? Oh, go on, you go, Councillor Patrick, you go. Can you do the microphone? Thanks.
I just wonder whether there was going to be any monitoring of who these orders are going to be placed against in gender and ethnicity. Yeah, we talk about in a previous piece of work about dealing with discrimination and supporting people from different communities, and we know that Black people especially are overrepresented in the mental health service. So I just wonder what monitoring there's going to be.
Thank you so much. There are a number of monitoring requirements embedded within the LPS, but if I may approach the question in a slightly different way in terms of how we can ensure that our practice takes a preventative approach, so that we actually don't get to the situations where we need to invoke the LPS. So if we at the stage of thinking about assessments and also care and support planning, we ensure that the care plans we put into place adopt a least restrictive approach, which means that the number of times or instances in which we need to invoke the LPS, we only do that unless it's absolutely necessary. So that would put in place some of the safeguards which would ensure that the LPS is used in a positive sense rather than in a negative sense.
Presumably the monitoring we will monitor on all those areas and keep close check on that.
Absolutely. Monitor and report as well, statutory GT2 reports.
Just very briefly, in terms of my question, how confident are you on it would just increase resource slightly?
It's very difficult to say at present, as because we do not have the final details of it. But I think we have to assume that at the initial stage, because we need to train the workforce and also take this as an opportunity to really visualize and do differently care and support planning, there might be some resource implication for us to consider. But that might be seen as an investment for better practice in the future.
No, thank you. That's been very helpful. I appreciate all the work that's been done, and thank you very much for that very informative presentation. I'm just thinking in terms of next steps. I mean, it may be that if and when we do have an implementation date, I mean, one area in terms of the different partners working together, and maybe when it is either we have an implementation period of the code of practice or when it's up and running, maybe a sort of particular further sort of more bespoke briefing on that, just to give us assurance of the level of the interplay between the different organisations, as I think you said as well, to stop duplication of work as well. How do you have a central depository of resource so all the Hackney, all the agencies can work together, and just understanding how that's being followed through. So that may be something we could possibly revisit in due course as a bespoke item. But thank you very much. I will therefore close that item, and I will just very quickly run through the other items. Item 7 was for noting the Mayor of London's 6 tests for health service configuration. Minutes of previous meeting, can I take those as agreed? Number 9, the work commission programme is in the agenda at the back. At the moment, for January, we're thinking Cllr Kennedy to give the cabinet members question time, and coming out of tonight, certainly if we can get Kirsten here for some focus on primary care. I haven't been notified of items of any other business. Members, if there are any other items you wish to address in January, please let Jalil I know. But with that, I will then close the meeting. Thank you, everybody. Thanks for attending.